So we're going to start in with what's called a Prezi. If you guys haven't seen this type of presentation before, it's actually kind of fun. If you tend to get motion sick, you might want to close your eyes every once in a while. So there's a reason why I picked this picture. The very obvious symptoms that you have: pain, neuropathy, brain fog, tiredness, changes in personality, inability to be as active as you wanted to be for many reasons, the GI symptoms, all of the different things that come with fluoroquinolone toxicity. Tremendous challenge for you. And what you're feeling is the proverbial iceberg above the water. What's below it is what's really challenging to really understand. There are many, many different ways that we can actually make somebody feel better through injections, IV therapies, even psychological counseling, different ways of healing heart and mind. But to really get down to the nitty gritty of all of the roots of what's going on, why it's happening, how it's happening, and how they interrelate is this stuff. Now, this stuff, the symptoms that you're having, don't necessarily get better as quickly when you're dealing with the underlying root causes, and sometimes you have to go backwards a little bit symptomatically to actually get better what's happening below the surface. This is what I mean when you might want to close your eyes. Sometimes it's a little bit fast on motion. But this is Regenerative Masters. That's a group of people, a group of providers in Minnesota that have been together for about 3.5 years. And then the Fluoroquinolone Antibiotic Awareness and Healing Alliance, which we started 1.5 years ago with the first conference in Minnesota. Dr. Woggon was at both conferences. This is the multidisciplinary approach, assessment, and healing of cervical injuries with fluoroquinolone toxicity syndrome. These are funner than PowerPoints. Who we are. Underneath all of this, everybody, we are a group of people who want to understand, synergize, and heal physical, mental, emotional, spiritual, energetic, intellectual, all the underlying pieces and parts of a human being. We want to get together and use our capabilities to help people heal. Because why? Ultimately, because we're selfish. This is actually tremendously rewarding for all of us. We've gotten past that stage in our careers where we have to use our careers to help ourselves feel better. And serving other human beings is really our singular goal. And selfless dedication to meaningful human transformation, more fulfilling than anything else out there. This is why I say we're a little selfish. I guess it's the best way that you can be selfish, but we're still selfish. My personal assistant, Haley, loves this sign. She wants to put it in our window.
You're right.
All right, that's a picture of the building on the outside. Interestingly, Matamira is a Dakota word that means White Bear Lake, which is our neighboring city. All right. These are things I didn't know and I didn't understand when I started doing regenerative therapies in 2007. Ultimately, this all comes down to mind, heart, and soul healing. I know you feel what you feel in your body, but mind, heart, and soul healing is where everything starts. And you are actually the group of people that taught me more than anything, because I kept digging, peeling back layers, trying to understand what I needed to do to be the best help for you. And it comes down to this. The body is easy at the end of the day, if we take care of heart, mind, and soul. And yes, I've seen miracles happen. So the little blurb about FAHA. Yes, it's alive, it's well. We have a Facebook group now, and we are the first fluoroquinolone national organization. 2 conferences. We have now patient education materials, newly floxed individuals with just a general info sheet for them. physician awareness campaigns. We've done multiple email mailings, standardized approaches. I'd like to say there's a standardized approach, but really it's just some deep perspectives to help us to understand how to unravel and unwind each human being at a time. We're looking forward to doing some training and teaching other sites. We have had to remove a couple of members who just were not working with us the way that we had envisioned. We wanted this to be a collaborative group of individuals who were selflessly sharing their information, understanding, and ways of healing individuals. And those who weren't doing that were duly removed. All right. That's just us. You guys can go back and look at this later on. That just lists everybody. I want to do a shout out to Heather Slusher, though. She's the current director for FAHA and has come up with a ton of her own ideas, ton of her own approaches, and has shared selflessly for both of the conferences and in between. All right. Here's something that I didn't know and I didn't understand until fairly recently, actually. There is an order to healing that has to be respected. For the most part of my career, I came from this direction, going down through structure and neurology while adding some physiology and emotional work. And it's just been the last few months where I've said, you have to come from the bottom up. You have to at least be addressing the deep emotional, energetic, and physiologic reasons for dysfunction before or in tandem with doing neurologic and structural work. If you don't, oftentimes you just lead to lots of flares and very poor healing course. So we're trying to figure out for each of these levels, emotional, energetic, physiologic, neurologic, what milestones do we need to get to before we're doing structural work? Because I know your Achilles tendon's hurt, but as you see a little bit later on, it's not that simple to just stick a needle into an Achilles tendon and try to get it to heal. There are lots and lots of reasons why Achilles hurts in fluoroquinolone toxicity and otherwise that we need to take into account. I'm giving you this slide to let you know how deep we get into this piece of the spectrum. I'm a highly technical physician, but to get this emotional contribution to pain degeneration together, has taken me a couple of years to do. And psychologists look at this and they're pretty surprised that we have something like this complex. But we have lots of tools in the chest for all of this. I'm going to tell you that working on the sympathetic nervous system and your deep emotional healing will have longer term benefits than anything else that we do. And it's challenging. I've recently come up with a group of what I call cheat codes for deep emotional healing or healing in general. And happy to share that with people as we get to know each other a little better. It's 39 different separate perspectives. Hey, just if somebody could yell out on the screen, are you seeing just what I'm presenting, or are you also seeing the faces on the side over here?
No faces.
Okay, cool. Thank you. Energetic. Dr. Mark Harris is a MD/PhD/ND in Bozeman, Montana. You guys may have heard of him before. He's an expert in many different things, amongst them mitochondrial dysfunction. He was at our last conference. He tied together about 6 different loose ends for me. Where do prayer, meditation, placebo effect, thought, intention, injections, how do these things all come together in one? He just looked at me and he goes, oh, that's quantum energetics of the body. Just offhandedly. And I'm looking at him, you know, like he had 10 heads and thinking, where did you come from? But you've heard of quantum mechanics or quantum physics. We have a quantum version of function in our body. This is energetically what's happening. For the individuals who've worked with energetic healers, that's where they're working. This layer is where they are working. Physical therapists, I'm convinced, as well as chiropractors, actually touching a human being may be the most important thing they do and not their technique.
So
Energy that they're sharing with you is extremely important.
sorry.
You guys want to mute, if you might want to mute if you're gonna make some noise, okay? Physiologic healing, this one is going to be covered separately by myself and Melissa Olson and myself and Heather Slusher in these Wednesday webinars. This is a lot to cover. A ton of physiologic improvement that we can work on. And the order that we do this in is extremely important. We don't want to just bring you in and start giving you some supplements until we know you need those supplements. And what order do we introduce those supplements in based on your physiology and your findings? What if you have mold? What if you have yeast? What if you have leaky gut? What if you have SIBO? All of these things are extremely important to our order of how we approach everything, because when you're doing interventions, I don't want those interventions wasted in parentheses on the fact that your physiology is in such bad shape that they're not going to work. Okay, neurology, huge piece of the equation too. This will have its own webinar. But we look at 6 different levels, from superficial, local, compound, nerve roots, autonomic and central nervous system, not to mention some of the things that modulate those things. By the way, fluoroquinolone toxicity often presents like complex regional pain syndrome, or CRPS. You might want to look that up, because that's how I approach nerve dysfunction in fluoroquinolone toxicity. Now, structure itself, this really fine lattice work in this picture, that's fascia. It is the basic structural unit of the body. Your structural unit is not your bones, it's actually your soft tissue, your fascia, your tendons, your ligaments, your capsules. And this can be the easiest or hardest thing to work on. Depends on how well you prepared the person. Okay. There's another way to look at that flow diagram. It's turned upside down compared to the other one, because emotional trauma, energy in this layer, neurology, physiology, cellular health, all the way down to tissue deterioration. I thought tissue deterioration was all I was going to be doing my whole career, and I was grossly wrong. Why do we want to go deep with this? Being complete, assuming nothing, listening to the patient. I had a fairly well-known Floxy in 2011. I don't go back to 19 something, who, when I told her that it was all collagen problems because the Achilles studies had just come out in the black box warning, she looked at me a little half-cocked and sent me 80 studies on nerve dysfunction and fluoroquinolone toxicity. So I listened to the patients. Why? You guys have sometimes more time to look at fluoroquinolone toxicity than me. Happy to have you guys out there doing research and sending it to me. And how do we get healing and symptom improvement to differ? I'm going to say that thing on the bottom down there, extremely important, keeping your ego in check. If we're not here as selfless servants to care for you, and we're doing what we're doing for no other reasons as part of our life calling, the ego is always going to get in the way. And I've seen it over and over and over again in my career, from multiple different angles. Enough said about that one. Okay, looking at that structure just a little deeper. This is where I said we're going to talk about that Achilles a little bit. There are about 12 studies on non-fluoroquinolone Achilles interventions, and the consensus is it's a terrible failure. Regenerative injections don't work. Well, they don't work if you don't look at the nerves coming from the back, the sympathetic nervous system at centrally in the lumbar spine, local sympathetics, alignment, mechanics, posture, strength, stability, muscle activation, adhesions, calcifications, local nerves, bursa, radiation, gut. Yeah, you know what? Of course it's a failure if if you had stepped on a wasp's nest and you just pulled out one wasp out of the hive and hoped that the rest of them didn't sting you. Yeah, that would be a poor intervention too, to just kill one wasp at a time. I've never used that metaphor. That just popped into my head. All right, now the subject at hand, Floxy neck. First black box warning was in 2008 for Achilles rupture. And these got to be really smart drugs to know that they can only attack the Achilles tendon. There are no other black box warnings for other specific tissues in the body. However, we could go through the pathophysiology of exactly why collagen is affected as it is by fluoroquinolones. There are three different mechanisms and some overlapping ones from mitochondria and nerves. But one of the most common denominators of fluoroquinolone toxicity is collagen destruction and dysfunction, including in large arteries. This is why the aortic aneurysms is in the differential or in the black box warnings. And I even have Floxys who have had aneurysms in other places in the body. Now, I want to frame the pertinence of this, and I think Dr. Woggon is probably going to underline this as well. All previously injured tissue, degenerative tissue, neurocompromised tissue are at high risk for pain and dysfunction. Why does that matter for the neck? Because the upper neck is the barometer and keystone of all spinal function. And spinal function, I'm going to say this as an MD, the chiropractors are right, is what neurologically sets the function of the rest of the body. It's where all of our information comes from. And if we don't have that working well at the upper cervical spine, everything contorts around it, causing dysfunctions down the road, upper back, shoulders, lower back, and all of the areas that are dependent on those areas as well. These injections are extremely technically difficult to do. I use ultrasound and fluoroscopy to do them because they're that difficult. And when you have things like a third of your brain's blood supply kind of getting in the way of your needle, sometimes you better dang well know what you're doing and where you're going. It's enough said. I don't want to scare anybody, but it's highly technical. And I'm going to say that the neck being treated appropriately is going to affect the rest of the body more than anything else that we can work on. Yes, even the Achilles. Okay. Assessment for Floxy neck. It's going to come down to the imaging in this case, and there's no better imaging than actually watching what your body in real motion is doing when under imaging. Dr. Dennis Woggon's chiropractor in St. Cloud, Minnesota, Clear Institute founder, and he's a international expert in scoliosis. He got into upper cervical work because it affects scoliosis. One of the primary things that affects scoliosis. He's one of the founders of FAHA. So please, everybody, give him, I suppose, a silent thank you for today. And we will let him now share. And Dennis, is yours going to come up now?
I think so.
Where are you?
Should be here.
I'll share this one. No, not that one.
Is that working now? Am I on?
You're not, and we had this going beforehand. Where are you? Is this you? No.
Well, it says I'm sharing right now.
That's what I'm going to be sharing. Wonder if I can choose you.
I think you can. Before it was just the two of us, so.
Who was there?
I'm going to say stop my share. There you go. You see that now?
Oh, yeah.
Is Dr. Woggon's PowerPoint coming up now, everybody?
Yeah, it's up.
Perfect.
Except I've got to get. There we go. Okay, that should be up now. Can everybody see my screen?
Yep.
Yep.
Good.
I see.
Thanks, Dr. Ron, for letting me in here. My name is Dennis Woggon. I've been a chiropractor in St. Cloud, Minnesota for 47 years. I graduated from Palmer in 1974. So I've been doing this for a while, and recently Dr. Ron introduced me to the whole fluoroquinolone thing. It's something that you guys understand, but most practitioners don't. Most medical doctors have no clue, of course, and even chiropractors don't. So I think this is just really important, and look at all the different aspects of it. That's where we came up with the term Floxy neck, because it's a whole different type of situation. I've been working with the DMX for about 13 years. I'm one of the international speakers for the DMX Works company. Being able to see what's going on there is really important. Now, musculoskeletal symptoms are in 73% of patients with Floxy necks. And that should be neuromusculoskeletal symptoms, not just musculoskeletal. You're looking at the tendon ruptures, the tendinitis, weakness, joint swelling, the whole thing with the tendinosis. But it's much more complex than that. The whole picture of this is just gigantic. So the largest structure is basically the tendons and also the ligaments. Now, what happens is ligaments and tendons are split into small entities called fascicles, and they contain the basic fiber of the ligament. Get out of here. Okay. And there's a structural characteristic at this level. What I'm really coming at here is that we're starting to look at the whole collagen thing, and the collagen is the core, the very center of it. So if we go ahead and look here at a ligament or a tendon, okay, we've got the outside sheath, then we've got the fascicle, then we've got the fiber, then we've got the fibrils, and the very center core is the collagen. And fluoroquinolones destroy the collagen. That's like the whole core, like your core muscles. This is the core of all collagen material. What you have to realize is that collagen material makes up every part of your entire body, everything from arteries, tendons, ligaments, even the mitochondria. So this is why it's so far reaching, because the fluoride is actually a neurotoxicity, and its ability to destroy the collagen, I think, is just amazing. Fluoroquinolones have the same effect on ligaments as well as tendons. We've all heard about the Achilles tendon and how common that is, but the ligaments are also reacting as well, the same way that tendons do. So tendons connect muscle to bone, and yeah, that's important, but ligaments connect bone to bone. That's a very important collagen complex, and I think it's even more important than just connecting muscles to the bone itself. You know, we understand the whole thing when we see this muscle breakdown with fluoroquinolones with toxicity, but when we start to look at the ligaments, they're the integral part as far as stability goes, as far as the spine. So we're finding the same damage, and that damage is apoptosis. And what apoptosis means is cellular death. It's destroying the cells of the collagen. I've been seeing this with the digital motion X-ray for quite a while. Sometimes I didn't understand it. The New England Journal of Medicine just about a year ago published an article stating that the digital motion X-ray is the best way to find any type of injury as far as the body goes. It's better than CAT scans, it's better than MRIs, it's better than what's called video fluoroscopy, which is somewhat similar, but this is a much more precise picture. Being able to understand this is very important, especially when you've got something that has a black box warning, which most people don't know about either. So we start to look, these are ligaments here. We've got alar ligaments, we've got atlanto membrane ligaments. This is all in the upper neck area. So the second vertebra is the axis, the top vertebra is the atlas. We've got the occiput up on top. So we've got three areas here, the occiput, the atlas, and the axis. There are no discs in that area. And what's important about that is when we get an MRI, MRIs are going to show us the disc. Well, it doesn't show us anything about the occiput, atlas, and axis at all. So MRIs miss 30% of the entire spine, and this is the most important part of the spine. The first vertebra is called the atlas. The second vertebra is called the axis. Do you know what the third vertebra is called? Third vertebra. And then fourth vertebra, fifth vertebra. So none of the others have names. It's like if I had a whole bunch of kids and I first called the first one Elijah Woggon, second one Tristan Woggon, third one would be third Woggon, then fourth Woggon, and fifth Woggon. In other words, that upper cervical junction, the CCJ, is extremely important, and yet it's overlooked so commonly. So this is looking at the spine from the side. This is in the AME Journal of Whole Body Impairment, 5th edition, chapter 15, pages 371 to 392. It talks about a slippage here, and this would have to do relative to the anterior and posterior longitudinal ligament. So it has a tendency to slide backwards and forwards. Anything over 3.5 millimeters is considered 25 to 20% whole body impairment because of spinal instability. And it actually states that this instability is worse than having a vertebra that is actually crushed, broken, or collapsed more than 50%. So this instability is really a big deal. If you go down to Mexico, they have all kinds of drugstores there, and walking around town, you can find Cipro any place, right next to the Viagra. So I guess if you're going to buy Viagra, you got to buy the Cipro too to go along with it. It's just so common. I have a patient who's a pharmacist in Canada, and she said when patients check into the hospital, the first thing they give them is Cipro. That's the #1 antibiotic, and you guys know how bad that is. And it's just terrible the way they hand it out like candy, without any warnings, without ramifications. It's very important to me right now whenever a patient comes in, I get their past history as far as what have they taken for antibiotics, but I want to know the name of the antibiotic. It's like, oh yeah, I took antibiotics for urinary infection. What kind was it? What's the kind the doctor gave me? So we realize there's got to be a much more important history going along with that. So here's the type of fluoroquinolines you all know. It's the Cipro, the Levaquin, the Tequin, the Evilox, Acuflox, and the Roxin. All of them are pretty much the same. They have that relative risk as far as side effects go that can actually destroy a person's life. They're actually a systemic broad spectrum of antibiotics. They eradicate bacteria by interfering with DNA replication. DNA is the building block. So even right now, when we look at some of the vaccines that are affecting the RNA, which is actually a genetic typing, messing with the DNA is not a good thing. Fluoroquinolines are relatively ineffective against intercellular pathogens. They're used as hospitals as a first line of antibiotics, even though they have a black box warning. FDA is advised they're not suitable for common conditions such as sinusitis, bronchitis, urinary tract infections, and yet they give them out all the time for that. They should be given only if it's a matter of life and death, and that's it. I think you're all probably familiar with Dr. McCullough, and he actually published a whole bunch of real interesting information on this quite a few years ago. He says fluoroquinolones are the most dangerous drugs in the market, and they should be avoided unless your life depends upon it. Despite the dangers, they're the most commonly prescribed class of antibiotics. In 2010, Bayer's top 2 fluoroquinolines, Cipro and Evilox, brought in over $1 billion in sales. So it's kind of like follow the money. Johnson & Johnson sold $1.3 billion worth of Levaquin. And all these things have side effects. But fluoroquinolines, especially with their fluoride base, they can cause serious permanent injuries and even death. Despite the harm of the normal risk, doctors frequently prescribe them as the first line against infection, and they don't warn the people about them, not even the side effects. So they've got fluoride as a central base, and we know that fluoride is a neurotoxin. There's even information on the side of toothpaste going, don't eat the whole thing because it has fluoride in it, which could really be bad for you. But fluoride can actually cross the blood-brain barrier, which makes it such a potent neurotoxin. In other words, there's no filter between the two. And then it disrupts the collagen synthesis, and it can also damage your immune system by depleting the energy reserves and inhibiting antibody formation in your blood. So there's a whole cascade of effects that goes on here, and the treatment of it is going to take an entire team. Now, this is when we start to look really at the harmfulness of the fluoroquinolines. First of all, it can inhibit or disrupt the central nervous system, and that's a big deal, the central nervous system, the GABA receptors. So it has an entire effect as far as the nerves go, depletion of magnesium and disruption of cellular enzyme function. And this is why enzyme therapy can be so important. Disruption of mitochondrial function and energy production. The mitochondria are basically collagen. And we start to see right now, especially how important that mitochondria as far as the body function goes and energy in life, and that causes oxidative injury, lack of oxygen, and cellular death. So a lot of the side effects of them, you get the pain, the tingling, numbness, malaise, weakness, headaches, anxiety. Like I said, 72% have neuromuscular problems. 42% of them have ringing in the ears, visual problems, smell problems, hearing problems, cardiovascular with the heart, 36% in patients like tachycardia, skin reaction, rashes of 29%, gastrointestinal 18%. I mean, these are just amazing side effects. You can also have retinal detachment because of the collagen in the retina and cause blindness. And actually, the collagen degeneration has a lot to do with the tendon cartilage and especially the ligaments, nausea, diarrhea, acute kidney failure, psychotic reactions. And there's a big problem with anxiety correlated with this, as well as brain fog. And usually they 1/3 has a negative psychiatric effect, anxiety, personality changes, confusion. I see this a lot with the fluoroquinolone patients, hearing problems, rashes, sensitivity to light, liver toxicity. So the idea is, how can we really see what's going on here? And this is my digital motion x-ray machine. It takes 30 x-rays in 1 second, but it's like 1/1000th of normal radiation. So it's really a low amount. But by taking 30 x-rays in 1 second, I can get a moving picture, a motion picture of the entire spine. Now, I can show you an x-ray or an MRI, and you can't tell me if that person's alive or dead. It's just a static picture. But when I can see that moving as far as the digital motion x-ray goes, the DMX, I can see what is normal function and what is abnormal function. We can't really see the ligaments on the DMX, but I can see the effects of ligament damage. For example, if I look outside, I can't see the wind blowing, but I can see the flag blowing in the air, and the harder the flag is waving, the more wind velocity. In that same way, we can come down and correlate the amount of ligament damage by the amount of abnormal motion. This is just a chart. The MA, which is milliamps as far as radiation goes, is about 2 with the DMX. Average X-ray machine is 100. So there's 50 times less radiation there. So it really is a minimal amount. Now, when we look at the spine from the side, this is what a normal curve should look like. And it's the front and back ligaments, the anterior and posterior ligaments that actually hold it into position. Now, the spinal cord goes through the spinal canal. So the spinal canal is the home, the environment where the spinal cord lives. And where you live is kind of important. The problem is when it becomes straighter, the spinal canal will increase 24% in distance. So what happens then is that the entire nervous system, the spinal cord, is stretched 24% longer. And inherently, the spinal cord will stretch maybe 10% for the entire length, but not 24%. So you're getting a lot of adverse mechanical tension directly on that central nervous system. So this is a picture here. This would be a normal curve, okay? And this, we're looking at the dural sheath. But on the right here, we have the spinal nerves. And you can see how they're kind of lax and they just kind of enter the body coming from the spine. When we go into that Lassa curve or kyphotic neck, we get a smaller dural sheath. It's kind of a compression of the spinal cord. But look how tight these spinal nerves are here on the bottom right. So these are the nerves that are going out into the hands, the arms, the legs. That amount of abnormal tension disrupts the normal neurological communication. And the curves give the spine flexibility and strength. So this is a patient in 1961. They had a curve there. They were in a car accident in 65. See how this lower neck started to go backwards? That's called the kyphosis. Now, because that area is stressed, it's weaker. So what happens is the body will bring in calcium to try to make it stronger. And that calcium is known as osteoarthritis. So this is 65. Here's 1968. You can see the disc degeneration and the bone spurs in this area here. There's a process called piezoelectricity where actually it attracts positive calcium ions to negative effects in this area caused by abnormal pressure. Here's 1974. Look how that entire area has changed. So anytime there's a loss of curve as far as that neck goes, what we're looking at there is eventually 100% of the time it's going to lead to disc degeneration. But probably more importantly is that abnormal pressure directly on that spinal cord. The central nervous system, that spinal cord, is 6 times more sensitive than peripheral nerves. For example, just take your finger and stick it against your eyeball. That'll give you an idea how sensitive that is. So here we're looking at the upper cervical spine again, where an MRI isn't going to show anything. We've got the occiput, the atlas, and the axis, and a whole area of different ligaments here. One of the most important ligaments here is called the alar, A-L-A-R. And that ligament connects the axis to the head, the occiput. It doesn't attach to the atlas. So the atlas is kind of free flowing in there. It can do a lot of different crazy things. In that upper cervical spine, if I turn my head, the spinal canal will occlude or get smaller by 50%. So in rotation, say example, turning your head to back out of the garage, you're going to start having problems if there's alar damage there. So this is where the dens is here. This is part of the axis. Here's the atlas. You can see the space is larger on the left side than it is on the right side. And that's an indication of this alar instability. So we can actually see with the digital motion x-ray how we start to get slippage here as far as that spine. I can go back and forth and look at this atlas, okay? And there's actually slippage of the atlas right on top of the axis. Okay. Now in rotation, here's the atlas and here's the axis. You can see how far it slides off on that side. Okay, on the opposite side, okay. So here's the rotation. It's a check ligament, a little bit there, but look how far it slides off on the opposite side. And that alar is extremely important because when you get that disruption, that's right where the brain and the spinal cord come together. That's where the spinocerebellar tracts are, which control all the muscles in your body. That instability relative to that alar ligament has a lot to do with chronic headaches, a lot to do with anxiety. I don't know if you remember, but back in 3rd grade, we used to do the snake bite where you kind of twist and turn on a person's arm. That's exactly what's going on in the very top area of that neck when you have alar instability. And the other thing is that there's a lot of brain fog that correlates with that as well. Fortunately, with what Dr. Ron has been doing, there's a lot of ways to go ahead and stabilize that through some of the muscle activation techniques, through proper chiropractic care, through a lot of the work as far as the PRP, the prolotherapy. So this is a very similar DMX of a Floxy neck. We can see how there's a severe loss of curve, and you can see how this vertebra, the axis, is way off. Atlas isn't moving here very much like it should. Okay. And when she puts the head down, see how the second vertebra moves in front of the third moves in front of the fourth moves in front of the fifth moves in front of the sixth. There's a ligament here called the posterior longitudinal ligament that's been completely disrupted. And this destruction of the collagen has everything in the world to do with that. And then looking up, we start to see that same slippage, but we're able to actually measure this. We can actually measure this in millimeters to quantify the amount of instability in that area. Okay. We can actually, a lot of times we're going to see problems with that jaw itself, with the TMJ joint, the temporomandibular joint. There's a dysfunction of that. We get an unequal motion as far as the jaw goes. Again, everything dealing with the fluoroquinolones. Here's the occiput, atlas, and axis again. And when she tilts her head, look how far the atlas has slipped off there. That's really rare. It's present in about maybe 5% of the general population. Present in about 95, 98% of fluoroquinolone patients. Here's that right side. And a lot of neurosurgeons will actually do surgery to fuse this entire area together because they don't know what else to do with it. And it's a very serious surgery because if they're off by 0.5 millimeter, they could paralyze that person forever. At the end there, what you saw was there's an area in the upper neck that has hypermobility or too much mobility. Hypermobility, too much motion, is just as bad as hypo or not enough motion. Now, this is a test we can actually do. You can actually do this at home to see if there's alar instability. You have the patient look straight ahead and close their eyes and then look up at the ceiling. It's called extension. And just have them going up and down, and that should be exactly straight tracking. If the head goes off to one side, that's a sign of alar instability on that side and definitely should be evaluated. So Dr. Ron and I have been working together for, I think, about over 4 years now, finding out where these problems in, working together, trying to figure out the best ways to stabilize that. With some patients, we can do some simple exercises, working the rectus capitis major muscle, which will actually help stabilize it because it attaches from the axis up to the occiput. One thing that is extremely important, if you have a Floxy neck, or any problems as far as with fluoroquinolones, never let a chiropractor manipulate or crack or pop your neck, not manually. What I always use is an instrument called the arthrostim. It's very effective, it's very precise. It doesn't put any abnormal torque or twisting motions onto that neck. Because what happens if you get these types of manual manipulations and manual adjustments on the neck, all it does is stretch those ligaments more. You're going to feel better for about 20 minutes, and after that, you're going to feel like your neck should be popped and cracked again, and it should not be. Anytime you've got hypermobile segments, it's extremely important that area not be manipulated manually. There's a phone number there. You can actually call up the company. They can tell you who in your area has an arthrostim. I'm in St. Cloud, Minnesota, and with the Clear Scoliosis Institute, I love working with scoliosis. But when you put fluoroquinolones on top of a scoliosis, like I said, ligaments hold the bones together. It just creates a disaster. But what I've done is with the Clear Scoliosis Institute, it's a nonprofit organization, and I've trained probably over 1,000 chiropractors, maybe closer to 2,000 as far as how to work on that neck. When I tell a chiropractor they should be popping and cracking a patient's neck, that's kind of their sacred cow. So I don't have a lot of friends sometimes in the chiropractic profession, but there are a number of them that I have trained. And in order to find those, all you have to do is go to the clear-institute.org website. There's a list of doctors there that I've trained. They all have the arthrostim. They don't all have the DMX, the digital motion x-ray, but they know how to stabilize the neck, how to adjust it, and how to work together for the benefit of the patient and not let egos get into position. Okay. Dr. Ron?
I'm back.
Does anybody have any questions? Let me just stop real quick here. You can unmute, and if you got my email address, if you want to email me, that's fine. I'm here for you to help any way I can.
Dr. Woggon mentioned that he doesn't have very many friends in the chiropractic community, probably about as many friends as I have in the MD community. Somehow when you dedicate your career to helping other people heal, somehow you end up being an outcast. That's what I call the clinic. That's one of my nickname for our clinic, Regenerative Masters, is the Clinic of Misfit Providers. For those of you who are too young, you don't know what I'm talking about. That probably just aged me a little bit. All right,
I have a question.
go ahead.
Is this gonna just keep continuing to do damage to us slowly, or do we got to stop it before it gets worse, or how long does this keep up? I mean, it's funny that this came up, this showed up. I seen Darla posted it about your video tonight, and just about a week ago, I woke up, my neck was killing me, and it never went away. Now I'm thinking maybe it's Foxy neck, because I mean, it's like my hands got wrinkled, my arms got like kind of wrinkled, my muscles turned to like jello, you know, and it don't seem like it's getting better. And I'm gonna be 4 years in September, And I mean, I walk the dog and stuff, but it's like a struggle for everything, you know, it's like I'm struggling every step. And I mean, yeah, I mean, I do like a half a mile a night, you know, and walk them a couple blocks and then back, but it's a struggle. I really don't want to, but my dog's so cute and he's a new puppy. So, I mean, I just do a lot for him, but it seems like my whole body's just like, it seems like it's just like, it ain't getting better.
Yeah, so
Uh,
two
is this-
things, Jim. Number one, when the neck starts to show up as a significantly symptomatic area, that means that all of your accommodation and mechanisms to offload it have failed. Because everything contorts around, especially the upper neck, to allow it to keep your spinal cord and the brain stem safe. And if you've lost that ability and you're now starting to get symptoms, pain, headaches, changes in hearing, changes in vision, changes in mood.
my ears never stop like buzzing and ringing. And
Yeah. So
right
that's
when
that's one of the symptoms. That could be central neurologic direct abnormalities. That could be peripheral. That could be the neck. There's a lot of pieces that go into that. And then the other thing is, I adamantly will tell you, I believe everything can heal. And there's a very, very, very big equation for 40 different things to do, potentially, or perspectives or pathways to figure out to understand how to heal one human being at a time. You guys made me do this. It's your fault. I didn't
Yeah.
try. I didn't
Well,
try to put this all together. I just couldn't leave the entire idea of helping someone heal alone. So I will look at it like this, and I think Dr. Woggon should talk about this a little bit too. We've all had injuries. We've all had motor vehicle collisions. We've all had fall off the monkey bars. We all had our older brother push us down the stairs. Or we had a very aggressive doctor that wrenched on our neck when we were getting born. And you know what, we all probably have some degree of upper cervical abnormalities. I'll let Dr. Woggon talk about that for a minute.
Yeah, we all get various types of trauma, but it's how we can respond to that trauma. I mean, you go all the way back to the foundation as far as emotions and how that affects the entire body. You know, are we going to blame somebody else for our problems? Or are we going to accept responsibility and do something about it? The other thing is, a lot of times we'll start with a small problem, then it is compounded with another injury, micro trauma on top of micro trauma on top of micro trauma, where it gets to the point where it's kind of like the straw that breaks the camel's back. So the idea is, you know, what are you doing as far as your health goes? It's very important to eat properly, make sure that you're getting enough sleep, getting the proper nutrition is real important. Chiropractic care is essential to our body as far as making the whole thing function. It just has to be done correctly and make sure, you know, the first idea is do no harm. But when we start to see these problems, we have to be able to listen to our body. Just kind of what you're doing right now when you start to feel that neck isn't working right. Instead of ignoring it, figure out something to do about it. Just taking a towel and rolling it up and putting it under your neck to bring that lordosis in, does that make it feel better? When you look down like text neck and you're texting for a long time, does that give you a headache? Does that cause neck pain? If it does, maybe you shouldn't be texting with your head down. Different things here that we just understand the difference between good posture and bad posture, and listening to our bodies. And then when there's a problem, you know, find the right person that can help you.
Hey, Dennis, can you shout out the phone number for ArthroStim, please?
Yeah. Just a second. Phone number is 1-800-569-8624. So 1-800-569-8624. The name of the company is Impact, IMPAC, but the ArthroStim is the adjusting instrument. This thing actually fires at 6 hertz, which is 6 cycles per second. The nervous system responds at 333 milliseconds. So there's 1,000 milliseconds in 1 second. You can blink your eyes 3 times in 1 second. That's how fast the body can react. The average car accident takes place at 200 milliseconds. It's so fast, it's just a bam and it's done. When the art system fires at 6 hertz, it comes out to 167 milliseconds. So it fires so fast that it's kind of going through below the neurological threshold, and we're actually able to put a force in there. The other thing is the chiropractor should be able to take a before x-ray, do adjustments, and take x-rays afterwards, and you should be able to see changes on that poster after x-ray. If they can't do that, find somebody different. It's a matter of being able to do objective qualification of what you're doing, to really show that you're making a change there and not just loosening up joints and stretching the joints. And then the other one is the Clear Scoliosis Institute. It's just clear-institute.org, and that's with a list of all the doctors that I've trained are on there.
Thank you, Dennis. Chloe's asking if we can have neck damage without noticing it. Yes, because we have a function called proprioception. It's position sense. It is most prevalently, or it's most, the most number of proprioceptors are in the upper cervical spine of anywhere in the body. That sets, that's why I said that's your barometer. It kind of sets the keystone for the rest of the spine in terms of its alignment, its motion, its muscle contractile patterns. And because it's so protected, you might not notice what's going on with your neck, but you'll notice it everywhere else. So it's kind of like starting a line of dominoes behind a curtain, and you know, you didn't see the first 10 dominoes that fell. You see the next 15 that fall, and you think that those are the problems, but they're not. You got to go deeper than that from a structural and neurologic standpoint. And we lost us. And then Alsaris, did you want to, did we cover your question?
Hi, I would like to ask, when noticing cervical instability after being floxed, is it advisable to wear a brace in order to prevent further damage, or what are your opinions on this?
So it's a little bit of a mixed bag. Thanks for asking. I like it if you're symptomatic. So if you're having pain, head heavy, having trouble holding your posture, then it's a good idea, because you're going to start to create abnormal posture motions, alignments, as you try to accommodate for your symptoms. But on the other hand, you don't want to wear it so much that the neuromuscularly you get weaker and weaker and weaker and more dependent on it. So you need to find a middle ground for using braces. Some is good as long as it's helping to extend your functionality. Too much is not good.
The other thing too is that the joints of the neck are synovial joints, and they heal better with motion. So just to brace that for a really long period of time is going to lead to additional degeneration. One thing I think is real important as far as using like a neck roll, or you using a towel that you can roll up and lie on that to keep the good lordotic curve into your neck. If you go to the Clear Scoliosis Institute website and do a search on exercises, there's a group of exercises that'll come up that are just general as far as neck stabilization goes, to work the extensor flexors and help the whole body as far as healing goes, plus an explanation about how to roll up a towel where you kind of fold in half and then fold in the middle so that's a soft area for the spinuses. So you can find more information with that. But like Dr. Ron said, it's a matter of stabilizing the neck without interfering with it at the same time and giving it the ability to heal. Lying in the neck with a neck roll, lordosis, is going to give it the best opportunity to heal in position rather than out of position.
And then Kelly, did you have a question? Did we lose Kelly?
Yes, my name's Kelly from Seattle. I really appreciate the visual aspect of how the collagen is responsible for the cells into the tendon. I appreciate that, as well as explaining about the TMJ can be responsible too. I mean, I thought I was having sleep issues because I was dreaming that I was having dental flaws coming out of my mouth. I was like, what's wrong with me? But it was the tendon giving me issues. And then I woke up with arm pain, neck pain here and here. And I was like, what? It was just like a domino effect, you know, last year, TMJ, and then here, and then my arm. And it's just, it confirms what's going on with me. I appreciate that. Thank you.
Thank you.
You're welcome. I'm going to throw up a PowerPoint. I'm just going to show you where some of these injections go. This is literally like a weekend conference for me to start to teach people where to put needles and how to put them there. So I don't want to, it's kind of a little bit beyond, you know, the idea of doing this kind of webinar, but I want to show you at least a couple of things, partly because it's what's exciting to me.
Got to go on here and ask a question.
This is what's known as a nerve hydrodissection. This is under ultrasound. You guys seeing this?
Yep.
Okay.
Mhm.
So that's my needle going in. This happens to be the median nerve, which is the nerve that gets entrapped in carpal tunnel. But this is the kind of precision that we can use for imaging and opening up different areas that are impinged, that are that have adhesions around them, that are stuck in their fascial planes. This is known as a microsurgical technique for obvious reasons. And it's one of 15 different microsurgical techniques that I've been around to help develop over the last 15 years of ultrasound guided procedures. So imagine that in multiple areas. When I'm doing a stellate ganglion block, these are the kinds of things that I'm doing to open up the tissue around the sympathetic nerve supply so that it's not adhesed and not irritated.
Now, Ron, on that video, that needle looks really, really big. You want to give them an idea how big it really is?
It's very blown up. That's a 27 gauge needle. That's actually the size of a needle that we use to numb the skin.
Good.
But you know, I have to be at least a little scary to everybody, otherwise they think that was too nice. So let's see. This was a talk I was giving to upper cervical chiropractors. Things that get in the way of these kinds of therapies for upper cervical injections getting, you know, being the gold standard. That's roughly what it looks like when I'm doing an ultrasound guided injection in the upper cervical spine. So that's one kind of visualization I'm using. I've got lots of other different kinds of pictures of me doing different things. But there's me going back and forth. That rounded area from left to right that you see, that's the head, the back of the head coming down. Then you'll see me going back and forth between this, and then eventually I'll get fluoroscopy in here too. And I've now got about 3 or 4 different ways, depending on somebody's anatomy, of how I approach these joints, these very, very, very important structures. You see my needle coming down from right to left there. And right under my needle about right now is the vertebral artery. That gives you about 1/3 of your brain's blood supply. You kind of want to see that in real time, soft tissue visualization. So after I got past the vertebral artery, I got down, my needle actually touched down on bone. And then I pull in the next set of visualization, which is fluoroscopy. Then I'm able to take a look and see, where is that needle? I'm sorry, it gets a little bit flooded out here, so you can't see the needle that great for you.
Ron, they want to know if the patient is awake or asleep.
In between. They have Xanax on board and typically have had a stellate ganglion block by this point in time. So they're typically not real awake. I will tell you though, has anybody ever picked up a cat by the nape of the neck? What does it do? It freezes in place, right? Humans do kind of the same thing. I've only had one patient in the last 13 years that I couldn't do cervical injections on because they were moving too much. Everybody seems to just pretty much freeze.
But the patient's not under anesthesia where they're knocked out cold.
Not knocked out cold, no. I actually want to ask Do you feel that? Is that somewhere that you sometimes have symptoms? In the future, I will do nitrous oxide for people who really can't stand the idea of having any kind of symptoms while you're being injected. But for right now, very few people are much more than mildly uncomfortable. Okay. That's a fast version of that procedure. When I started doing these procedures, it took me 15 or 20 minutes to do what you just saw me do in about 3 or 4 minutes. And this will keep going, but I don't want to belabor that. Now, can you guys see my cursor up there?
Yes.
Good. All right, so that's a needle coming up. That's the C0, C1 joint coming in right there, but that's all the ligaments over the top of it. So this is the C1, 2 joint coming through right here. You can see it better on this side, but it's coming through right here. C1, 2 joints up here, and I'm getting the ligaments to actually spread all the way up over the C1, 2 joint, which is right here. And you'll see these. Now this is the C1, 2 joint. There's a little contrast in this one from previous injection. There's some contrast going in there. I just want to show you how, just how clear I'm able to see all these things under fluoroscopy.
And this is what helps stabilize that alar ligament instability.
Yeah, there's 2 ways to do that, and I'm glad you brought that up, Dennis. There's 2 ways to do that. You can either try to get the needle directly into the alar ligament, which is known as the pickle procedure. That's done at Regenix in Colorado. They go through the back of the throat to try to get the needle right into the alar ligament directly. What I decided was, now I worked with them. They're excellent practitioners. I worked with them for 4 years. The direction I went after I left there was to go into the inside and outside part. Let me go back. I get the capsular ligament that's right here and the capsular ligament that's right here with alar instability, because the alar is going to come up here from the dens upward toward the occiput. And this movement and some rotational movement of that joint are going to secondarily take up the stress that the alar ligament was meant to take. And these things can't get injured uniquely. You don't just pop an alar ligament. There's a lot of other structures that end up having to be injured at the same time. So just doing an alar ligament is not sufficient. You still have to do all the other things that were injured at the same time. Now, what I forgot I was going to show you is right here, this little bit of black right here. That's actually contrast that's going from inside this joint up into the epidural space and spinal canal region. That's a torn C1, 2 joint. It's called an incompetent joint, not because it's stupid, but because it's torn. And there's special things that I do for those when I see that.
Ron, one other question. If the patient can't lie down on their stomach, is there another way to get around that?
Hesitantly, we can sit up. I've done it for a couple of people. I would prefer to find another way to do it, use pillows and buttresses and really keep you in place as much as possible. This is the C2-3 joint, and you can see the whole joint outlined right here. It again is incompetent. This is contrast material flowing into the epidural space. You keep going down now. Understand, I've gone here, I've gone in here, I've gone in here. Now I'm in this joint. All these are ligaments that you're seeing lighting up along here. I did this intentionally so that you could see that all these capsular ligaments are massive amounts of stabilizing material. That's just the posterior aspect of them I'm injecting. Oftentimes I get into the lateral aspect of it over here as well. That depends on the DMX. If the DMX shows lateral instability, then we go into the lateral ligaments, which is a good thing because you guys don't need to know this, but I like to pontificate about these things. The medial branch nerves that go to the facet joints are in those planes. And if I loosen those up a little bit, then we're able to get the nerves not being quite constricted, so they're not quite as abnormal. This one too is incompetent. It's flowing into the epidural space here from this joint. And this is just a rapid set of injections to show you. This is up above C1 going into C2. Now the spinal cord is and the brainstem are about right here, back to about right here, which is where the ligamentum flavum is. That's the ligament that's just posterior to the neural elements. So I can get about this far in to work on the ligaments that are in between the spinous processes. These are the bones that you can touch with your fingers if you push in the back of your neck. And the supraspinous and interspinous, so that's about as far as you can get with a needle. There again, I mean, right there is about as far as you can get with a needle. So I'm deep in the interspinous ligament there. There's some contrast going into it, and that one actually leaks just a little bit up in the upper part of it. But then I inject into it, and it fills all that ligamentous structure right there extremely well. You cannot do this blindly. You can't do it fully with just ultrasound. You can do it really well with just ultrasound, but there are things that you cannot do with just ultrasound. This keeps going down, and I keep doing more and more and more. These are a lot of the very common injections that I do with the neck. So the temporomandibular joints, the sternoclavicular and acromioclavicular joints, that's the joints that are on both sides of the clavicle. One is up against your sternum and the other one is up against your upper shoulder joint. The first rib, the second rib, the greater occipital nerve, the lesser occipital nerve, the greater auricular nerves, the atlanto-occipital membrane, the anterior longitudinal ligament, the discs. I don't often do discs. They generally don't need to be done. Sometimes the brachial plexus needs to be dissected, like you saw me do the injection of the median nerve. Intramuscular injections, extremely important. Subcutaneous injections, very important. These are some still images that versions that Dr. Woggon was showing you. Now over here, this is why I want to get these inside and outside ligaments out here, because if the alar ligament is holding you in rotation and with some bending, guess what? Those have to be weak if the other one's weak too. None of these things happen in a vacuum. If these were perfect, alar ligament tear wouldn't allow this to move. These things happen in concert with each other. This is that rotational view that I like this a lot. This helps me plan procedures a lot. But you can see the decreasing amount of overlap that's happening from over time with her. This one you can see it tremendously actually. There's about 4 or 5 millimeter gap there. That goes down about a millimeter and a half. And now this goes down to barely discernible anymore. That's tremendous change over time. This is just me letting you know, listen, true healing happens over months. Soft tissue changes for 6 to 12 months. For sure 6 and up to 12. Nerves 12 to 18 months. That includes your proprioceptive function, that position sense that we talked about. So I tell everybody, listen, this is not a popular message, but feeling better after a day or a week or a couple of months isn't healing. That's symptom relief. And if you want just symptom relief with return of symptoms, that's what you do. You just will keep going after symptom relief. You just described allopathic medicine. But healing medicine happens over months, and it takes determination. And I'm going to tell you, hopefully mind, heart, soul healing together with the body. Why? Because then we've truly served you. Let's see. That's my old procedure room. My new one's much cooler. You'll have to come and see it. And where is it? Oh, my Prezi shut off. While I get this Prezi back up, why don't you go ahead and yell up some more questions.
Dr. Hanson,
Yeah.
if one thought that one had occipital neuralgia and not flox and had surgery to sever the nerves and they were tucked in, and now I've got tucked in nerves in the back of my neck plus scar tissue, theoretically, if there was someone as stupid as that would do that. What's involved here? You know, there's both scar tissue and entrapped nerves that are not entrapped naturally, but they're entrapped because they were cut and tucked into muscle, as was a technique at the time.
So that's some very, very advanced hydrodissection that you're talking about, because the greater occipital nerve is pretty small. Generally a problem right at the back of the occiput.
Sorry, the graders were removed. These would be the lessers.
Oh, okay. Lessers, they wrap around the sternocleidomastoid and then come up over the ear. And it's just identifying them and seeing where they're stuck in the fascial planes, and then doing what I call fascial plane restoration.
Can you describe a little bit of what that is? I've had different techniques to try to soften the scar tissue. Nothing really helps, and it's causing a problem. If I shift my head one way, like like they used to do in the Egyptian, things, it just immediately sends everything into spasm because they're trapped.
So the way I look at that is, fascial plane dissection or hydrodissection is identifying your structure that's entrapped in all this scar tissue, and then using usually a 22 gauge needle under ultrasound guidance and following it, that structure, to see where it's entrapped in all this scar tissue while you're injecting fluid to open up the tissue. Now, if a 22 gauge needle with fluid pressure isn't enough, I have a couple of other things that I do. I use sometimes an 18 gauge needle. Sometimes I'll use a very small, what's called alligator clamp, to follow the nerve and open up the tissue. I don't know that many people that do that particular technique.
Would things like PRP and stem cells help at all, or is this just freeing the prisoner, or can you try to help with the tissue?
The freeing is the most important part, and doing PRP, or there are many different kinds of solutions that you can use for nerves. I have my 3 favorites that I use here. I've been doing intraneural inside the nerve injections for about 9 years. How you do that, where you do that, why you do that is a lot of technology. Those are some of the microsurgical techniques I've been talking about previously. Okay, is that showing up okay?
So bottom line, there's hope.
Always. There's always a way to figure these things out. Oh, on your own if you want to. Try nattokinase. And
I tried that.
Did you?
I'm highly reactive to a lot of supplements, as I'm sure a lot of Flox people are. It's very tough. Yeah.
So then go back to gut. That's immune system, endocrine system, all extremely important. I'm going to tell you that these are the guiding principles of care that regenerative masters have. You guys can go back and look at this later on to look at each of them. But we're, like, again, I said, the clinic of misfit providers. Now, what does all these perspectives look like as we apply them to fluoroquinolone toxicity? That's the easy version of this particular infographic that we created. And let's see, Foxy neck down here with collagen, but it's actually a neuromuscular collagen issue. Lots of underlying conditions that affect what's going on with fluoroquinolone toxicity. And all of these things put together, way too much for one brain to understand. I'll let you guys look at this later. These are all the things that we have right at the clinic. And again, this is just something that it took me 13 years to understand, to put these things together this way. We're going to talk a little bit in a minute about the newest updates of how we do this. For those of you who know Jerzy Cieskowski, this is his slide. And we're now starting to look into, not just starting to, making strides into looking at testing for the DNA adducts and how we would use that in our decision making in terms of how we would try to get the adducts to remove from your DNA. These are covered better when I've covered this previously. But I think that tells a little bit about FAHA. What I really want to avoid is the idea that, and you've heard this from me over and over again, there's no way that one person can do this adequately. just the regenerative injections part of it takes a big part of my mind. And I'm going to tell you, do you want to have the guy on the left be the guy that you're listening to, or do you want to, well, that might be fun and interesting, but do you really want to listen, or do you really want to listen to this where there's 100 different people expertly playing their instruments? And the other version of the one-man band, I'm a little disgusted with the idea that that physicians are telling you can't talk about what I do and don't share what I do or I'll sue you with gag orders. It's disgusting. And the other idea that's out there is, and this is part of the reason why we started FAHA, is listen, there's a lot of ways to approach human physiology, and just throwing something up against the wall and hoping it sticks isn't okay anymore. And neither is, hey, I'm going to go out to the Facebook sites and I'm going to let everybody else, kind of guide me that, even if they've had fluoroquinolone toxicity for 20 years, there's no single thing that happened for one person is necessarily reproducible in any other person. And I know it's people's desire and intent to help each other down this pathway. But there are places now, at least 2 of them in the country, where we can go to and be very specifically evaluated physiologically, imaging wise, your neuromuscular function, your mitochondrial function, putting all these things together so that you don't have to do guesswork. And that's just you guys can look back at this, so I don't take too much of your time tonight, but this is roughly what things look like for a 6-month period of time. And here's where I've switched now in the last few months. I used to have everybody come for 2 to 3 weeks. We would do all the different kinds of treatments together. It's a lot to do. It's still doable. We can do it, especially for people who have a difficult time traveling. But where I'm landing at this point in time is I want to do 1 week of very deep evaluation with imaging, with labs, with physical examination, with neuromuscular evaluation, treatment training, naturopathy, functional medicine, specific labs, all of these things in 1 week all together so that we can understand you. Do a fair number of treatments, sympathetic nervous system. We now have ketamine here. I think that's going to be a very helpful addition to people. That'll help the sedation piece of it, actually. I am doing a whole series of PRP injections on people with this first week visit. A lot of it is to calm down your sympathetic nervous system, augment your parasympathetic nervous system, and start to work on opening up and moving tissue that needs to be moved and helped. I can do a little bit of structure, but I'm a little hesitant to do that right now because working on structure will actually ignite your sympathetic nervous system. I want to calm that down initially. There's psychologists, intuitive healing, naturopathy, functional medicine, labs, physical, dietitian, all in this entire time together. It's a very busy week. Ozone shockwave, laser, all of this stuff going forward. The mild and some of the moderate people, this is likely, I'm believing, going to be all that you're going to need. Moderate, severe ones, you need to probably come back after a month or two, do more definitive, deep structural work. And that's my current way of approaching this. In a year, I may be saying something completely different, or at least a little different, because that's the way my life goes. This is what I want you doing, or whatever the heck your passion is, if it's scuba diving, or if it's underwater basket weaving, or if it's running after antelope, I don't care. I want you doing what you want to do.
Dr. Hanson?
Yeah.
Question on that week. That's resetting the nervous system, doing a whole bunch of other, I would say, non-invasive kinds of things. Are you now saying that you wouldn't do anything structural that second week?
Well, if people want to stay for a second week, I have done that with individuals. In fact, just last week, I was doing that with an individual. The one place in the body where I was, where I'd consider doing more advanced structural work would be the neck, because the neck is already set up to be able to kind of control everything. It's not a dependent part of the body. It's the driver part of the body. And you can sneak in a little bit more work on the neck without really preempting the rest of the process too much.
Thanks.
I will do a phone call with you for just, 15 minutes or so, and just to take you to kind of next steps. Haley and Angie are the experts in the clinic to start doing that with you.
Okay, thanks.
And we can open up for some more questions. Let's see if these chat questions had anything going on. How many injections? I'm going to tell you a number of injections. I'm injecting somewhere on the order of 30 to 40 sites with that whole group of things that I told you about. All the facet joints, all the ligaments, the sternoclavicular joints, the acromioclavicular joints, the temporomandibular joints and their ligaments, the first rib, the second rib. It's about 30 or 40 structures, very, very carefully worked on. So people are usually in the procedure room for an hour and a half to 2 hours. And that's pretty unheard of in the regenerative community, just because, frankly, nobody wants to spend that much time doing injections. When you stabilize the ligaments and they heal, does that help heal the discs in the spine? Kyle asked that. Yes, it either heals them or stabilizes them. What I found over time is in the cervical spine, it's rare that a disc is the driver of the problem. It's more the victim than it is the villain. The cervical spine, very, very facet dependent on its stability and its function. So if I inject it into a disc, and I can do that, it's not that hard to do. It's actually the easiest disc to get into. It's pretty easy to do, and I can show a nice picture showing that I did it. But if you don't work the ligaments and you don't do something to try to stabilize, restore posture, alignment, and motion, kind of doesn't matter that you did something into a disc. Let's see. Do I require communication with the patient during the procedure? No, some people are fast asleep on just Xanax. I like to have some communication with people just to see, is that where you usually have some symptoms? And will there be IV stems at the end? Depends if there's enough, and the FDA hasn't come in and said that absolutely you can't do that anymore, which may happen by the end of this month, actually. We can still do some IV treatments. Time between the first week and the returning, that's going to depend if you're in the mild category and you're working already on kind of the deep emotional and the physiologic work, probably 2 weeks to 4 weeks. And if you're a more severe case and there's a lot of physiologic work that needs to be done, mold toxicity, yeast, SIBO, leaky gut, hormones that need to be optimized, probably more like 2 months.
Dr. Hanson, you just mentioned something about IV stems. Sorry to keep asking questions. If the FDA does something about that, do you think they'd still allow the direct injection that you can do?
So far.
So they might distinguish between IV and hypodermic, the 15, 20, 30, 40, 50.
Correct. That's being fought right now between the FDA and what is the name of the group? And they're mostly in the Southwest United States. Self-Surgical Network. So that's, I think that's not quite done in the Ninth Circuit Court of Appeals last I knew, but I haven't looked in a little while. Yes, you'll be able to watch the video again. We'll get it all truncated and ready for you. Let's see. What am I injecting? Let's see. I get cells and tissues from blood, bone marrow, what I call vascular aspirate concentrates. That yet needs to be described in literature, so I'm not going to do too much of it here. There are certain things I'll do with adipose, with bone, with synovial fluid, and even cerebrospinal fluid. 7 different types of tissues and 16 different concentrates and 36 different combinations at last count. And that's based on what am I injecting, how bad is it deteriorated, and where is it in the body? Fred, probably because it works.
I
sounds a
was
little
I was
crass.
afraid you're going to say that.
It's probably a little crass, but
Yeah, it was a rhetorical question.
yeah. Andy, everybody asked me that question. Harvesting those fluids, it sounded like it would be, in parentheses, fun. Everybody asks, is this going to hurt? And I tell them I won't feel anything. The really quick ones, so that depends on if I kick you or not. But it's not comfortable having needle put into you, but I try to have you a little sedated, a little calm, sympathetically down-regulated. And let's see, and do some local anesthetic. Why did my neck pain get worse after laser treatment? Barb, probably, this is just a guess because I'm just pulling this out of thin air in a way. Because if your deep, or if your major mobilizing muscles, the ones you can touch, got relaxed because of the laser, then that stabilizing or splinting factor is now not a part of the equation. So you probably felt more unstable, and your deep stabilizing muscles were not turned back on. And so you had no abnormal stability, but you had no normal stability either. So those adapting mechanisms can be, they can help you for a little while in a short-term sort of way. All right, that's 8:30. For anybody who doesn't know my phone number, it's 612-800-5096. Or just look up Ortho Cure Clinic. I want to thank Dr. Woggon for being here with us. And everybody, I want you to understand there's always hope and there's always ways to heal. We are not healing you. We are not your healers. We are here helping your body do what it already knows how to do. We're just your cheering section, trying to just help along what your body can already do, or remove the challenges that keep it from being able to do that. And none of this is magic. It's all just very, very carefully, very heart-led and selfless care put together for you guys. We're gonna do another one in 2 weeks. That one will be myself and natural talking about something very exciting things like how do we get the quinolone molecule, and how do we get the fluoride out of the body using the body's own mechanisms, along with some very, very deep root level physiology that she's been working on. She's also an amazing individual in terms of working on heart and mind healing. So that's 2 weeks from now. There'll be a notice that goes out over the FAHA Facebook site and website. Cheers, everybody. Be well, and
Thank you.
Thank you.
Take care.